Hello, it's Dmitry again, and today we'll be going back to the Mehlman medical textbook, or medical PDF, I should say, looking back at the pulmonary section. This is going to be the part 2 for the pulmonary section. We're going to begin with high-yield alveolar fluid conditions. So we're on page 62 right now. I think we wrap up on 77, so this will probably be shorter than the previous video that we had, but, we'll have to see how it goes. Or, I guess if you're watching a recording of this, you know how it goes. So high-yield alveolar fluid conditions. Pulmonary edema. Due to left heart failure on USMLE, there is such a thing as non-cardiac pulmonary edema, that is to say ARDS, TRALI, or TRALI, discussed below in this table. But for USMLE purposes, if you see pulmonary edema as an isolated phrase, it refers to the translation of fluid into the alveolar spaces due to the increased pulmonary capillary hydrostatic pressure from left heart pathology. The pulmonary capillary wedge pressure and the LAP are both elevated. USMLE can give you a vignette of, for example, MI with shortness of breath, and they ask for the mechanism of the dyspnea in the patients, leading to an answer of increased alveolar arteriolar oxygen gradient. That is to say, the patient can breathe just fine, so alveolar O2 is normal, but fluid impairs the gas exchange, so we have low arteriolar oxygen. Cephalization of pulmonary vessels is buzzy and synonymous with pulmonary edema on USMLE, shows up in some NBME vignettes. Acute respiratory distress syndrome, or ARDS. The answer on USMLE for bilateral exudative chest infiltrates and decreased O2 saturation in patient following pancreatitis is aspiration of vomitus, near drowning episodes, aspiration of fresh/seawater, improper insertion of the nasogastric tube into the lungs with feeding initiated, toxic shock syndrome, or general trauma and sepsis. 2CK NBME question gives vignette of toxic shock syndrome and then asks the most likely cause of death in this patient. The answer would be ARDS. Pulmonary decompensation associated with the pancreatitis is very buzzy. Another 2C, the word buzzy is, okay, whatever. I mean, I've heard you say this multiple times now. Whatever. Okay, sure. It might not show this, but sometimes I wish there was an eye rolling animation that they have for the for the thing. It's like, oh, whatever, man. Okay. Another 2CK question gives patient who is brought to the hospital following near drowning episodes. Plus, they ask for the patient what the patient needs to be monitored for. The answer would be ARDS. The ARDS is technically defined as a PaO2 over FiO2 of less than 300, but the USMLE doesn't care. I've never once seen them apply this ratio or care. I emphasize up above the bilateral nature of ARDS because many questions give ARDS as a differential diagnosis for unilateral conditions, and it's wrong. So bear that in mind. If it's a unilateral issue, it's not ARDS. In theory, the patient can be ventilated as follows: prone positioning, patient on stomach, plus low tidal volume setting, plus permissive hypercapnia. IIRC, this is asked once on a 2CK form. An offline NBME question wants increased surfactant protein D as the answer in a patient who is recovering from ARDS. Apparently, surfactant protein D is a marker of lung injury and is increased in patients with ARDS or who are recovering from it. Call it weird all you want, but it's on the NBME. Transfusion-associated lung injury, or TRALI, or TRALI. The answer on the USMLE, if a patient has an ARDS-like presentation with bilateral crackles and low O2 saturation less than 6 hours following a transfusion, the mechanism is abnormal priming of the neutrophils in the lung that reacts to cytokines within transfused blood products. This is technically a type of non-cardiogenic pulmonary edema. Again, that's called TRALI, or transfusion-associated lung injury. So just kind of be aware of the history of the patient when it comes to something like a transfusion. Transfusion-associated circulatory overload, or TACO, aka transfusion-induced hypervolemia, differs from TRALI or the transfusion-associated lung injury in that it is a type of cardiogenic pulmonary edema. That is to say, the left heart cannot handle the increased hydrostatic pressure from the increased volume, so transudation into the alveoli occurs. A knowing diagnosis but presents two ways. One, if a patient with history of heart failure or MI develops respiratory distress following transfusion of repeated blood products, A 2CK NBME question gives a 72-year-old woman with a history of MI 10 years ago who gets shortness of breath and bilateral crackles 30 minutes after transfusion with crystalloid solution and 4 packs of RBCs. They don't specify the volume of crystalloid in the question. 2, they don't mention the history of cardiovascular disease, plus the vignette will sound exactly like trolley, greater than 6 hours following a transfusion. 2CK forms give an elderly dude. Oh wait, let me go back up to here. Yeah, so we said 2 here. The other possible presentation is, they don't mention the history of cardiovascular disease, plus the vignette will sound exactly like trolley, greater than 6 hours following transfusion. 2CK form gives an elderly dude who receives only 3 packs of RBCs, plus he develops bilateral crackle and low O2 saturation. But they say that this occurs 12 hours after admission, not the less than 6 hours as with trolley, where the answer is X-ray of the chest as the next best step in the diagnosis. The question doesn't rely on you discerning taco versus trolley to get it right, but the explanation says it's taco, because it's more than the 6 hours. So, in summary for taco, if ARDS-like picture after transfusion, if it's less than 6 hours, it's trolley. If it's greater than 6 hours, it's taco. If it's heart disease, then taco regardless of time frame. High-yield infection-related stuff. Pneumonia, lobar pneumonia, strep pneumonia on USMLE, right lower lobe consolidation with dullness to percussion, bilateral interstitial pneumonia, aka atypical pneumonia, in immunocompetent patients, mycoplasma on USMLE, lobar pneumonia where they say interstitial markings and strep pneumo isn't listed, giving you an answer of mycoplasma, and the word interstitial wins over location. Bilateral interstitial or ground glass pneumonia in AIDS patient would be pneumocystis jirovecii pneumonia, which is called PJP. Lobar pneumonia in AIDS patient will be strep pneumonia and not PJP. Bacterial pneumonia, specifically post-influenza infection, would be Staph aureus. Bilateral pneumonia plus low hemoglobin or positive Coombs test would be mycoplasma, which can cause cold agglutinins, which means that the IgM against RBCs, giving you hemolysis. Pneumonia plus hyponatremia and or diarrhea would be Legionella. Pneumonia plus business conference or residential home implies air conditioners, which would be Legionella. Pneumonia in 3-week-old neonate who had conjunctivitis 1 to 2 weeks ago would be Chlamydia trachomatis. The STI drains through the nasolacrimal duct to the lungs. Pneumonia in newborn first few days of life would be group B strep agalactiae, which is gram-positive cocci. If they say gram-positive rods, that's instead Listeria. If they say gram-negative rods, that's E. coli. So again, gram-positive rods, Listeria, gram-negative rods, E. coli. Pneumonia plus rabbits is Francisella. Pneumonia plus birdkeeper is Chlamydia psittaci, or shiitake, or whatever. So pneumonia of the southwest United States and or earthquake dust is coccidioides. The patients who has a lung cancer or prone to obstructive pneumonia on 2CK form. Pneumonia in CF would be Pseudomonas plus or Staph aureus. Pneumonia in patients with central venous catheter plus right upper lobe lesion would be the answer of Staph epidermidis on NBME. Catheter equals biofilms, or I would assume they mean catheter. USMLE wants for pneumonia adventitious / bronchial, that is to say abnormal breath sounds, plus increase in tactile fremitus. Air vibrates due to the movement through the infective consolidation within alveoli. Community-acquired pneumonia or CAP empiric treatment would be azithromycin on 2CK on NBME. This covers the atypicals like Mycoplasma, Legionella, Chlamydia, as well as strep pneumo. If the patient has been on antibiotics in the past 3 months or has severe lung disease, levofloxacin, respiratory fluoroquinolone, can be given first line. CAP, community-acquired pneumonia, that results in sepsis or septic shock, gives ceftriaxone. If listed, choose cefoxitin for peds. Non-sequelae pneumonia, that is to say hospital or ventilator acquired, requires coverage of Formosa and Pseudomonas. USMLE wants vancomycin plus either ceftazidime ceftazidime, a third-generation cephalosporin, or cefepime, which is a fourth-generation cephalosporin. For fungal pneumonia, treatment would be fluconazole. For fungal pneumonia plus a fungemia, which is high fever and chills, you will have to use amphotericin B. NBME for 2CK wants you to know sputum culture followed by blood cultures as done in all patients with pneumonia who are septic. What they do in this patient is give you patient who has sputum culture performed. Then they ask you what should be done for the next diagnosis. The answer should be blood culture. If you get pneumocystis pneumonia, jump straight to the bronchoalveolar lavage as the answer. If you get a patient who has chest x-ray on CT showing cavitary lesions in the lungs filled with a mass like Aspergillus fungus ball, they want open lung biopsy as the most confirmatory test. When a pneumonia fully resolves and USMLE asks why the chest x-ray is normal after the fact, the answer is maintenance of integrity of basement membranes, as you mentioned earlier. 2CK wants you to know about pneumonias can occur in patients distal to areas of lung obstructed tumors. The answer will be endobronchial obstruction as the reason that the patient has distal pneumonia. Same answer for why it can be distal atelectasis. NBME wants you to know that rituximab, which is a monoclonal antibody against CD20 on B cells, increases the risk for bacterial pneumonia. This makes sense since B cells are required for antibody production as part of the humoral immunity against bacteria. Bronchiolitis on USMLE. For a kid who's less than 18 months old who has low-grade fever and bilateral wheezes caused by respiratory syncytial virus RSV, the treatment is supportive care on USMLE. Don't choose answers like ribavirin and palivizumab. What about laryngotracheal bronchitis, that is to say, CRU? Well, CRU, caused by paramyxovirus, aka parainfluenza virus, presents as a hoarse, barking, or seal-like cough in school-aged kids. The question can say the cough gets better when his dad brings him out of the cold air. Next x-ray shows a steeple sign, which is subglottic narrowing, as you can see in the picture right there. Sometimes the question can give you an easy vignette of CRU, but then the answer is just larynx, literally inflammation of the larynx, trachea, and the bronchi. Subglottic means below the area of the vocal cords. The larynx is the area encompassing the vocal cords. The treatment is supportive. If they force you to choose an actual treatment, the answer is steroids, if listed, followed by nebulized racemic epinephrine. Epiglottitis, caused by the Haemophilus influenza type B, H-flu type B. Seen in unvaccinated immigrants can be unvaccinated, as well as patients with asplenia or sickle cell autosplenectomy. Can also cause meningitis. X-ray of neck shows the thumbprint sign. Presents as a child who has fever plus difficulty breathing. They can say the kid is drooling and or in tripod positioning, facilitates the use of accessory muscles. USMLE wants the intubation as answer. Epiglottitis is a medical emergency that can lead to sudden occlusion of the airway. Treatment equals third-gen cephalosporin, cefoxietine in peds, or ceftriaxone. Gives rifampin to close contacts. Bacterial tracheitis. Diagnosis of exclusion on USMLE, you eliminate to get there. Classically caused by Staph aureus, followed by a viral URTI, upper respiratory tract infection. Shows up on the 2CK form as patient with recent viral URTI who now has stridor, suggesting upper airway narrowing, plus no drooling, suggests against epiglottitis, can fully open mouth without difficulty, plus does not improve with racemic epinephrine, suggests against CRU. Being able to open the mouth without difficulty is important because this contrasts with the paratonsillar abscess, where the patient has difficulty opening the mouth fully. Pertussis. Classic whooping cough presentation as succession of many coughs followed by an inspiratory stridor. What you do need to know for USMLE is that this can absolutely present in an adult that they can be vague about it, just describing it as a regular cough. The way you'll know it's pertussis, however, is that they'll say that it's either hypoglycemia or post-tussive emesis, which means that vomiting after coughing episodes. Pertussis can cause super high white blood cell count in the 30 to 50,000 range, where there are more than 80% lymphocytes. This makes it resemble ALL, which is acute lymphocytic leukemia. So, you should know for peds that the ALL-like laboratory findings plus cough is pertussis. Question will ask number one way to prevent. The answer would be vaccination, not hard, but they ask it. Pertussis is part of the Tdap. Pertussis component is killed acellular. The tetanus and diphtheria are toxoid. The erythromycin can be given to patients with an active cough. USMLE doesn't care about pertussis stages. Close contacts should also receive erythromycin. And again, pertussis resembles ALL because it has these very high white blood cell counts, and they're 80% or more lymphocytic. Pleurodenia. Pleurodenia, as above mentioned in the cardio section, this is an MSK condition. I've seen it asked twice on the MBME that has nothing to do with lungs. Despite the name, it is viral infection, Coxsackie virus B, causing a sharp lateral chest pain due to the intercostal muscle spasm, also called devil's grip, by the way. Creatinine kinase can be elevated in stem due to the increased tone of the muscle. I'm going to take a brief break for a bit. Okay, I'm back. Let us continue with tuberculosis, which is a heavy one. Yep, yes, it's a lot. Tuberculosis. Mycobacterium tuberculosis has a unique cell wall composed of mycolic acid that is difficult to gram stain, requires acid-fast stain, produces a cord factor as on the NBME as a virulence factor, can present similar to lung cancer, where the patient can have B lymphocytes, that is to say B symptoms, that is to say fever, night sweats, weight loss, and hemoptysis. Living in a homeless shelter or immigrant status from endemic area is buzzy. I've seen rural India and Albania as two locations on NBME questions. Can cause cavitations and calcification in the lung grossly. On histo, causes caseating granulomatous inflammation. GON, foci/complexes are textbook descriptors for TB lesions, but not assessed eponymously on USMLE. Can cause constrictive pericarditis, can also calcify. Disseminated TB, miliary TB, can affect multiple organ systems, leading to psoas abscess, pot disease, which is TB infection of the vertebra, adrenal insufficiency, meningitis, osteomyelitis, and arthritis. The first step in diagnosis is PPD test, type 4 hypersensitivity. If the PPD test is positive, the next best step would be chest X-ray. If the PPD test is positive but chest X-ray is negative, the next best step would be treat for latent TB or give TB prophylaxis. This is isoniazid INH for 9 months plus a vitamin B6, since INH can cause B6 deficiency. It is exceedingly high yield that you know that neuropathy in a patient that can be treated with TB has B6 deficiency. If PPD and chest X-ray are both positive, and the next best step is treating for active TB, which is ripe for 2 months, plus RI for another 4 months, 6 months total. So ripe, rifampin, isoniazid, pyrazinamide, and ethambutol. The BCG vaccine is live attenuated. USMLE wants you to know that the history of BCG vaccine does not change management based on PPD guidelines. If the USMLE asks you how long after the TB exposure will someone's sputum culture be positive, the answer is 2 to 5 weeks. Interferon gamma release assay, quantiferon gold, can be used in patients who have history of BCG to decrease the false positives, but USMLE doesn't assess this. The reason I mention it is because they want you to know interferon gamma is required for simulation of alveolar macrophages to control TB. Patients who have interferon gamma deficiency or IL-12 receptor deficiency, IL-12 normally is elevated. IL-12 normally elevates interferon gamma, have increased susceptibility to TB infections. If the immuno stuff sounds confusing, I talk about this in detail in my high yield immuno PDF. TNF alpha also requires you to suppress TB. So TNF alpha is also required to suppress TB. There are 4 drugs such as infliximab, adalimumab, and etanercept increase the risk of TB, which is why they should be avoided in silicosis patients, as mentioned earlier. What is considered a positive PPD test differs depending on the risk factors. Greater than 5 millimeters positive, history of close contact to someone with active TB, immunocompromised patient like AIDS, organ transplant recipient receiving immunosuppressants, chronic corticosteroid user, calcifications on chest X-ray. A greater than 10 millimeter positive, healthcare workers or prisoner or / prison worker, immigrant from endemic area, TB laboratory personnel, children less than the age of 4. The greater than 15 positive, everyone else. If a PPD test is positive, never repeat it. If it is negative, it must be repeated 1 to 2 weeks, sometimes false negatives. Hot tub lung. Answer on the 2CK form for a guy who moves into a new apartment building with a hot tub and gets bilateral chest infection. Inhalation of fumes with Mycobacterium avium complex, or MAC. Pulmonary abscess. Pulmonary abscess exceedingly high yield in USMLE. USMLE wants aspiration of oropharyngeal normal flora or aspiration of oropharyngeal anaerobes as the cause. Okay. Question will give aspiration risk factors such as alcoholism, dementia can cause loss of gag reflex, history of stroke leading to dysphagia, or epilepsy. Question can also mention broken or missing teeth like hypodontia as a risk factor. Often described on NBME as pulmonary lesion with an air fluid level. This is buzzy but not a mandatory descriptor. This refers to that top half of the circle being air and the bottom half being pus. The latter is settling due to the gravity. Pulmonary abscess. The stem can say the patient has foul-smelling sputum. This descriptor is exceedingly high yield and is synonymous with the anaerobes on USMLE. Oropharyngeal normal flora equals Bacteroides, strictly anaerobic gram-negative rods, as well as Peptostreptococcus and Mobiluncus. Well, that's a fun name, Mobiluncus. The latter two are not high yield, but Bacteroides is. I mentioned it all three, however, because there is a question I can say sputum shows gram-negative rods, gram-positive cocci, and gram-positive rods, which refers to all three. But the bigger picture concept is this: mixed normal is all mixed normal flora. The treatment would be clindamycin. USMLE loves this. If the question tells you that the patient was treated for pulmonary abscess, plus a year later there's still a lesion on the chest x-ray, the answer would be failure of maintenance of the basement membranes. So here's the air and that's the fluid. See the little pulmonary abscess? There we go. Acute bronchopulmonary aspergillosis, or ABPA, presents as asthma-like presentation in patient with an increased sensitivity to aspergillus skin antigen. Hypersensitivity pneumonitis. Answer on the USMLE for bilateral lung condition, plus fever in farmer who has exposure to hay on new NBME. They will tell you the fever self-resolves after 2 days, and now is afebrile. Bisonosis, pneumoconiosis from hemp, is wrong answer, since this won't present with fever, plus classically presents in textile workers. Okay. Cryptogenic organizing pneumonia, or COP. Cryptogenic organizing pneumonia. Idiopathic restrictive lung disease where the patient has pneumonia-like presentation that fails to improve with antibiotics, not actual pneumonia. Formerly known as bronchiolitis obliterans, organizing pneumonia, or BOOP. That's a lot more fun. COP versus BOOP, what would you rather have? Someone boop your nose or somebody, pull you over? I'm not sure. It's a hard one to say. I think I'd prefer one or the other, I think I'd prefer the first one. Non-existent yieldness on USMLE. But I mention it because you will sometimes see this as a wrong answer choice, particularly on hard 2CK questions. And I've seen enough students erroneously pick it. So let me read that again. So non-existent yieldness on USMLE, but I mention it because you will sometimes see it as a wrong answer choice. Oh, that's fun. So, just for reference, if you see cryptogenic organizing pneumonia, it's almost certainly not that. Okay? Just bear that in mind. What about otitis media? Middle ear infection. Infection in the portion of the ear just deep to the tympanic membrane, most commonly the strep pneumo. Will present as red, immobile tympanic membrane. Immobility of the tympanic membrane is highly sensitive for otitis media, meaning that if the question says immobility is normal, we can rule that out. Ear tugging can be a sign in children of either otitis media or externa. Treatment would be amoxicillin or penicillin. Augmentin amoxicillin clavulanate is classically given for recurrent otitis media, so if you are forced to choose between amoxicillin penicillin alone or augmentin, go with the former. For 2CK peds, a tympanostomy tube, or aka grommet, the grommet is used, there's no Wallace involved, is used if the kid has a greater than 3 OM occurrences in the last 6 months, or greater than 4 in a year. Serous otitis media, that is to say, aka otitis media with effusion, presents as a fluid behind the tympanic membrane in a kid weeks after resolution of 1 or 2 otitis media infections. Almost always benign and self-resolves in 4 to 8 weeks. The answer is observation. Okay. Tympanic membrane perforation. Tympanic membrane perforation. Tympanic membrane perforation is the answer on the new 2CK NBME for 2-year-old who has 3-day history of viral infection followed by awakening with severe ear pain plus dried blood on the earlobe and pillow plus otoscopy cannot visualize tympanic membrane because the seropurulent fluid draining from the ear canal can occur due to the otitis media, although vignette on NBME doesn't sound like classic OM and is as described above. Yes, so it doesn't necessarily sound like a classic otitis media, as we described earlier, then it might be this tympanic membrane perforation matter. What about mastoiditis? Mastoiditis, inflammation of the mastoid bone caused by untreated otitis media. The mastoid process is the posterior part of the temporal bone that is felt just behind the ear. Can present as a painful ear pinna that is dispatched, that is to say, upward and outward. Diagnosis is made by the CT or MRI. X-ray is the wrong answer. Wrong answer, by the way. You have to do CT or MRI for mastoiditis. 2CK IM question, 2CK in internal medicine question gives a 2-year-old with a mastoiditis where the answer is CT of the temporal bone. Sounds wrong, but since this is the increased radiation for a kid, but it's what they want. So it seems weird, right? It seems like CT of the temporal bone, but the answer is actually correct for mastoiditis. Meningitis. Meningitis, isolated inflammation of the tympanic membrane, can be bullous, that is to say bullous meningitis, caused by strep pneumonia or mycoplasma. What about otitis externa? Otitis externa, infection of the ear, which is the outer ear infection, by the way. The name gives it away, right? The infection of the ear superficial to the tympanic membrane, classically caused by Pseudomonas. Increased risk in swimmers and diabetics. An NBME form has a necrotizing otitis externa as answer for black skin within the ear canal in a patient. This is aka malignant otitis externa. USMLE wants acetic acid alcohol drops as prophylaxis in college students who does crew positive continues to have water exposure. Treatment, not prophylaxis, would be topical ciprofloxacin hydrocortisone drops. What about sinusitis? Sinusitis. The answer, if they tell you a school-age kid has lingering fever after an upper respiratory tract infection (URTI) for 10 to 14 days, would be sinusitis. Whenever a URTI lingers for more than 10-ish days, you want to think about sinusitis as a differential. A 2CK vignette gives you a nocturnal cough, reflects aspiration in this case, from the sinuses and gray membranes in the oropharynx. The gray oropharyngeal membrane detail sounds weird, since that is a normal buzzy for diphtheria, but it shows up on the NBME question where the answer is sinusitis and diphtheria is not listed. IgA deficiency questions would present as a recurrent sinopulmonary infection can say patient has a history of pneumonia, presents today with sore left cheek, reflects sinusitis. For 2CK, the CT scan is done if chronic sinusitis is greater than 12 weeks. After CT is performed for chronic sinusitis, nasal endoscopy can be performed. Treatment is amoxicillin/clavulanate augmentin. This is in contrast to the OM and strep pharyngitis, which are treated with just amoxicillin or penicillin alone, without the clavulanate unless recurrent. I'm going to take a brief break again. Okay, we're back, and I just had to like an Irishman's tweet or reply, just be a little bit of a reply guy for a little bit for an Irishman's tweet. So duty calls. So anyway, influenza. Influenza causes respiratory distress, fever, and myalgias, muscle pain. For USMLE purposes, the myalgias are exceedingly high yield as a vignette finding that usually suggests the flu over other diagnoses. Has 8 segments, 2 of which are hemagglutinin and neuraminidase. Hemagglutinin mediates viral attachment to the cell by enabling its binding at sialic acid receptors. If a question asks about the molecule most flu vaccines are targeted against, the answer is hemagglutinin. Neuraminidase allows for newly synthesized viral particles to leave the host cell. This enzyme cleaves sialic acid residues, which normally bind the new viral particles within the cell. Once these residues are cleaved, the viral particles can leave the cell. Drugs such as oseltamivir and zanamivir are sialic acid analogs that function as neuraminidase competitive inhibitors. In other words, they prevent the virus from leaving the cell. If the USMLE asks which drug prevents viral spread within a community, or they tell you that a drug is given and how the hosts are packed with virions because they can't leave the cell, the answer is one of the mivirs, either the zanamivir or like oseltamivir, which is I think what I've heard more typically. Antigenic drift is the point mutations in hemagglutinin and or neuraminidase where the virus has changed slightly. It leads to seasonal epidemics because, again, it's slowly evolving over time. Antigenic shift is due to the 2 influenza viruses entering a cell, one of human origin, the other of animal origin, such as a bird or a swine, where they engage in reassortment of viral segments, leading to a completely novel influenza virus. It leads to the generational pandemics. And the reason that happens, just to give you a hint, is because the body is basically used to the human form of the virus. And so the sort of normal variation or genetics you would see of the human viruses, the viruses that normally infect humans, the body's more familiar with that kind of virus, right? But if you try to introduce a different type into the environment, it's going to be unfamiliar with it and won't be able to defend it against it as quickly because it's so much more genetically deviant from what it's typically seeing. And as a consequence, it can more rapidly spread and cause issues, obviously, because the immune system just really isn't equipped to deal with it as easily. Hence why there's generational pandemics. If a patient gets a bacterial lobar pneumonia following a recent convalescence from influenza infection, USMLE likes Staph aureus as a high-yield cause. The USMLE will not play trivia where they list Staph aureus alongside strep pneumo, and you're forced to choose. What they'll do is say something about how a guy recently recovered from viral illness in which he had a high fever and myalgias. And now he has pneumonia caused by gram-positive coccus in clusters, leading to an answer of Staph aureus. In contrast, strep pneumo is gram-positive diplococci. Internal medicine IM intramuscular maybe in this case killed vaccine start age is 6 months. They give you yearly in the fall or winter throughout the life. Safe to give during pregnancy. Intranasal live attenuated vaccine ages 2 to 45, immunocompetent non-pregnant persons only. Coronavirus, the virus specifically known as SARS-CoV-2 or COVID-19, causes the 2019 global pandemic. The SARS stands for the Severe Acute Respiratory Syndrome. The pandemic is believed to have started following a laboratory leak in Wuhan, China, although this has been a source of political debate, where the initial explanations asserted that there was a natural zoonotic origin for the virus, that is to say, originating from animals, that is to say, bats. Has characteristic spike proteins that create a crown-like appearance on electron microscopy. The spike proteins bind to the ACE2 receptor, allowing for viral infection with host respiratory epithelium. Presentation can range from mild respiratory symptoms similar to that of the common cold, like rhinovirus, all the way to severe respiratory disease with multi-organ failure. Many different vaccine types exist, that is to say, mRNA, Moderna delivers mRNA coding for the spike protein, viral vector, AstraZeneca delivers the mRNA in a harmless viral capsid, and killed, Sinovac delivers inactivated killed virus. Both live viral infection as well as vaccination are known to cause rare side effects such as Bell's palsy and myocarditis. Although these effects are not unique to coronavirus, and they can rarely happen with many viral infections and vaccines. Vaccination and mandates and their political implications were, and still are, a source of contentious debate. Prior to the 2019 pandemic, coronavirus was known to cause SARS, or SARS I should say, in China in 2002, and Middle Eastern respiratory syndrome, MERS, in Saudi Arabia in 2012. Vaccination schedule for children now recommends intramuscular vaccine starting at 6 months, 2 to 3 doses. Vaccine stuff. Strep pneumo, PCV15 at 2, 4, and 6 months, then again at 12 to 15 months, age 65 and older, PCV20 once OR, or PCV15, then PSV23 a year later. For asplenia/surgical splenectomy, sickle cell, cochlear implant, CSF leak, chronic renal failure, nephrotic syndrome, HIV, and immunosuppressed patients, extra dose of PCV15, followed by PPSV23 8+ weeks later. Influenza. Intramuscular killed vaccine, started age 6 months, then give yearly throughout life, safe to give during pregnancy. Intranasal, live attenuated, ages 2 to 45, immunocompetent, non-pregnant persons. Coronavirus, intramuscular vaccine starting at 6 months, 2 to 3 doses. High-yield pediatric-related respiratory stuff. Tracheoesophageal fistula. High-yield pediatric condition in which the proximal esophagus ends in a blind pouch, plus the distal esophagus connects to the trachea. Will present as a neonate who coughs up milk with initial feeding. Highest yield point about TEF or tracheoesophageal fistula is a diagnosis made by insertion of nasogastric tube, which cannot be inserted fully because it hits the blind pouch of the esophagus. In NBME, question wants endoderm as the abnormal embryology for TEF makes sense since esophagus is epithelial lining of the gut, that is to say for the endoderm basically. It says here, since esophagus is epithelial in the gut, endoderm. Choanal atresia, weird condition in which the nasal passage don't develop patency, so the neonate is just obligate mouth breather. Oh, that's weird. Or present as a child who becomes blue hypoxic because while breastfeeding. Oh, okay, yeah, that's an important. Okay, yeah, I see. Because he can't breathe through the nose. The cries become pink once he then cries and becomes pink once detaching from the breast. Similar to tracheoesophageal fistula, diagnosis is made by insertion of a nasogastric tube, part of charge syndrome, coloboma of the eye, hole in the eye, heart defects, atresia of the choana, renal defects, and genitourinary anomalies, ear anomalies. So it might be part of a constellation of symptoms. Okay, congenital diaphragmatic hernia, one of the highest yield PEDS conditions on USMLE, caused by failure of formation of the pleural peritoneal membranes. Always occurs on the left side, where bowel from the abdomen can herniate up into the left chest. Can present as decreased bowel sounds in the abdomen plus increased bowel sounds in the left hemothorax. Vignette might say that there are cystic appearing areas in the left hemothorax, seen on chest x-ray, loops of the bowel. What about neonatal respiratory distress syndrome, or NRDS, aka hyaline membrane disease? The answer on USMLE for respiratory distress in kid who was born less than 34 weeks gestation, due to insufficient surfactant production by the type 2 pneumocytes due to the decreased lamellar bodies, the specialized organelles that produce surfactant. These kids have decreased lecithin/single myelin ratio, i.e. less than 2.0. Normally it is 2 to 2.4. Another name for the lecithin is dipalmitoyl phosphatidylcholine. This is asked on the NBME. USMLE can give simple vignette on NRDS and then ask for various manipulation of the ratio. That is to say, elevated sphingomyelin might be an answer. Makes sense since this would decrease the ratio. Decreased surfactant production means a decrease in alveolar compliance and an increase in the elastic recoil. Surfactant is hydrophobic and normally prevents the alveoli from collapsing. So if it's deficient, the hydrophobic interactions of the alveolar wall enable the increase in collapsing elastic recoil. Chest X-ray shows a reticulogranular appearance, very buzzy and high yield. In order to prevent NRDS, a pregnant woman gives birth less than 34 weeks gestation and must be 2 boluses of corticosteroids within 24 hours of parturition, which accelerate the fetal lung maturity. For example, there is a 2CK question where they tell you a woman giving birth at 33 weeks gestation was given a bolus of corticosteroids 12 hours ago. They ask for the next best step, leading to an answer of bolus of corticosteroids. Sounds weird because they said that was just done, but she needs 2 boluses. Okay, for management, 2CK wants tactile stimulation first, then place warming lights. The sequence is high yield, then give exogenous surfactant and oxygen. So again, tactile stimulation, then warm lights, then give exogenous surfactant and oxygen. Transient tachypnea of the newborn, TTN. The answer in USMLE when the vignette sounds like NRDS but the kid is term. For instance, they'll say neonate has difficulty breathing, but then you'll notice that he's greater than 37 weeks. Usually it's seen following a C-section or fast vaginal delivery. Mechanism is insufficient time for the pulmonary lymphatics to clear amniotic fluid from the lungs. The chest X-ray shows a fluid with fissure lines. Okay. Bronchopulmonary dysplasia. Fibrotic lung disease in an infant caused by continued use of supplemental oxygen. Vignette will give you a kid who was born at 26 weeks gestation who was in ICU on oxygen plus now is 4 months old and is now on home oxygen. They will say the EKG shows right axis deviation, plus or minus chest X-ray shows increased pulmonary vascularity. This reflects the RVH, right ventricular hypertrophy, ensuing cor pulmonale from pulmonary hypertension caused by the bronchopulmonary dysplasia. Foreign body aspiration. Answer on 2CK for kid under the age of 2 who was crawling around on the floor who now has acute onset respiratory distress. The vignette will then add 1 of 2 features. 1, unilateral hyperresonance in one lung but not pneumothorax, and 2, unilateral atelectasis plus ipsilateral tracheal shift. The exam will ask for bronchoscopy or fiber optic examination of airways as the answer. Again, bronchoscopy or fiber optic examination of airways. Allergic rhinitis. Not limited to kids, but it can be part of atopy in patients with asthma. Cobblestoning of nasal mucosa is buzzy for allergy. This is the same word as used to describe the tarsal conjunctiva in allergic conjunctivitis on peds. NBME 9 for 2CK has the use of a pillow and mattress covers as the answer. Otherwise, USMLE wants intranasal corticosteroids as the first-line medication. USMLE does not want antihistamines as the first-line med. Second-generation H1 blockers like loratadine are the answer if the intranasal corticosteroids are not listed. Oral prednisone is a wrong answer. I've seen students choose prednisone and then get irascible and say, but you said steroids were first line. Yeah, bro, intranasal, not oral. So intranasal corticosteroids. Adenoid hypertrophy. Just know that the enlarged tonsils, adenoids, are known to cause a stridor in pediatrics. Answer would be tonsillectomy would be the answer. Okay. Peritonsillar abscess or quinsy. Pus collection causing pain and swelling at posterior oropharynx can be seen as a complication of tonsillitis. Patient can have difficulty opening his or her mouth. This can contrast with the bacterial tracheitis, which is where the patient can fully open his or her mouth on the 2CK NBME, where this detail is important in an otherwise vague vignette. So you see a soft palate with the mouth, tonsil and uvula without abscess, but now you have an abscess. You can see the abscess near the sort of close to the tonsil, and it is blocking the mouth a little bit. Laryngomalacia, or Malacia. Most common cause of stridor in infants. Laryngomalacia is the most common cause of stridor in infants. Softening of airway cartilage. Vignette will give a kid under the age of 1 who has noisy breathing that is mitigated when placed prone on stomach or upright. Self-resolves almost always, that is to say, don't treat. Vascular ring. Weird cause of stridor that USMLE likes to contrast with laryngomalacia. Vascular embryology embryology variant can lead to airway compression. In contrast to laryngomalacia, mitigated when neck is extended, the treatment would be surgery. Velopharyngeal insufficiency. High-pitched, hypernasal, or whistling speech in patients with a history of cleft palate due to shortened palate, with or without repair. It is the answer on the 2CK NBME, so now that it exists, they will simply just give you a vignette on the cleft palate plus ask when the kid is at risk for. What the kid is at risk for. Cholesteatoma. Idiopathic squamous proliferation in middle ear behind the tympanic membrane that presents as an enlarging mass. Can cause obstructive hearing loss plus grow into the inner ear. Requires surgery. Rounds like the obscure diagnosis, but... So it sounds like an obscure diagnosis, but it's not. Be aware that it exists for peds. Tracheomalacia. Not pediatric, but I'm putting it here because I see it confused with laryngomalacia. This tracheomalacia is a cause of stridor in usually adults who have stridor developing months post-surgery, caused by a history of intubation leading to softening of airway cartilage. Just know this diagnosis, it exists. Don't confuse it with laryngomalacia. I'm going to take another brief break again, I think. We're on page 74 now. We have to do 74 up to 77. Okay, I am back. Let us continue with the last section of this video. Differentiating viral versus bacterial upper respiratory tract infections. The Centaur criteria are exceedingly high yield for IM. If 0 or 1 point, the URTI is unlikely to be bacterial. That is to say, it's likely to be viral. If 2 to 4 points, the chance is much greater that the URTI is bacterial. So here's the criteria for Centaur. 1. Absence of cough. That is to say, no cough is 1 point. If the patient has a cough, it's 0 points. Fever is greater than 38 degrees. Tonsillar exudates. Lymphadenopathy, cervical, submandibular, etc. So basically, if you have an upper respiratory tract infection and you have none of those things, so let's say you have all of them. You have an abscess, you have no cough, you have a fever, you have tonsillar exudates, and you have lymphadenopathy, then you're probably going to have a bacterial URTI. If you do cough, you don't have a very high fever, it's lower than 38. You don't have tonsillar exudates, and you don't have lymphadenopathy, then it's more likely to be viral. There is a version of the criteria that includes age, but on the USMLE, it can cause you to get questions wrong, so just use the simplified above 4 points. If 0 to 1 point, answer supportive care or no treatment necessary, or warm saline gargle, same as supportive care. For acetaminophen, latter is answer for 3M with viral URTI plus fever on MBME form. If 2 to 4 points, next best step would be rapid strep test. If rapid strep test is negative, answer throat culture, not sputum culture. Throat culture. While waiting on the throat culture results, we send the patient home with amoxicillin or penicillin for presumptive strep pharyngitis. If the child is let's say for example 12 years old and develops a rash with a beta-lactam, the answer would be beta-lactam allergy. If the vignette is a 16 or 17-year-old who has been going on dates recently, there will be no confusion. The USMLE will take it clear, gets a rash with the beta-lactam. The answer is EBV mononucleosis. Therefore, do a heterophile antibody test, monospot test. Remember, Epstein-Barr virus is called the kissing disease. Epstein-Barr virus is an odd virus out that usually presents with all 4 positive Centaur criteria and presents like a bacterial infection, but it's not. It's Epstein-Barr virus, right? This is why it's frequently misdiagnosed as a strep pharyngitis. This is high yield to know that beta-lactam is given to the patient with EBV may cause rash via hypersensitivity response to the ABX antibiotic, I should say, in the setting of the antibody production to the virus. EBV in a patient who does not receive antibiotics can cause a mild maculopapular rash, but the rash with beta-lactam positive EBV causes a more intense pruritic response generally 7 to 10 days following the antibiotic administration on the extensor surfaces plus pressure points. That's interesting. So remember, you might have a situation where they have something that looks like strep pharyngitis, they give them antibiotics, and all of a sudden the body freaks out about it. That's probably Epstein-Barr virus. So, what about ventilator settings nonsense? Students will sometimes nag about pedantic ventilator settings information. The vast majority of it is garbage for USMLE. What I can basically say is that the increasing PEEP, positive and expiratory pressure, is probably the answer 4 out of 5 times. Positive expiratory pressure is 4 out of 5 times the answer for any ventilator setting types question. The Q question might give you a big 15-line rambling paragraph where they're not sure what's going on, and then the answer is just increase PEEP. PEEP, again, that's the positive and expiratory pressure, keeps the alveoli open longer, thereby facilitating gas exchange. When the patient is on a ventilator, the general aims are keep FiO2 as low, as close to room air as possible, i.e. high O2 can cause free radical damage. Keep tidal volume as low as /normal as possible, i.e. 400 to 500-ish milliliters. High tidal volume can cause ventilator-associated barotrauma. increased PEEP if it means lower FiO2 and tidal volumes can be achieved. But the above needs to be taken with a caveat. For example, the question might say that the patient is on a ventilator and has arterial PO2 of the 40 mmHg, normal is 80 to 100, plus FiO2 is 100%, plus tidal volume is 1,000 milliliters, and the answer will be increased PEEP. The students say, wait, but I thought you said we want to reduce FiO2 and tidal volume. Sure, but we can't do that here because the PO2 is super low, so that we can only exacerbate it further. As I talked about for ARDS earlier, you could be aware that the triad of 1, prone positioning, 2, low tidal volume mechanical ventilation, and 3, permissive hypercapnia can be implemented. A very high yield point is that decreased CO2 causes cerebral perfusion. This is why patients faint in panic attacks, which is as of NBME. The first step in managing would be to increase the intracranial pressure is intubation plus hyperventilation. They can also ask the inverse of this NBME, i.e. they can say an anesthesiologist wants to increase the patient's cerebral perfusion, and the answer is decreased respiratory rate, causes increased CO2, which leads to increased cerebral perfusion. Ventilator-acquired pneumonia, or VAP, should be treated with vancomycin plus either ceftazidime or cefepime. Vancomycin not only covers MRSA, but also is effective against some high-yield resistant strep pneumo strains. Ceftazidime, third-generation cephalosporin, and cefepime, fourth-generation cephalosporin, are very effective against Pseudomonas, which is high-yield nosocomial organism for VAP. That is to say, ventilator-acquired pneumonia. Patients should be ideally weaned from ventilators as quickly as possible. USMLE also likes patients who are sick on ventilators as sometimes having euthyroid 6 syndrome, i.e. they will say patient cannot be weaned from ventilator plus has a decrease in T3 and a normal TSH. The answer would be euthyroid 6 syndrome. The full array of arrows are a decrease in T3, an increase in RT3 or T4. I think it says decrease in T3, increase in RT4, basically the same levels of T4. So decrease in T3, increase in RT3, about the same T4, and about the same TSH. If you have no idea what I'm talking about, then I recommend going through my High Yield Arrows PDF. If a patient ever has a high CO2, NR3344 mmHg, the answer can be ventilatory insufficiency. This applies to both patients on and off ventilators. Do not be confused if they give you an increased respiratory rate. New NBME form gives rough respiratory rate of 40 with an increase in CO2 as an example. Sometimes patients have shallow breathing despite increased respiratory rate. High-yield pulmonary drug points. Bosentan, endothelin 1 receptor antagonist used for pulmonary hypertension. Endothelin as a vasoconstrictor increases in pulmonary hypertension. There's an NBME question where a guy is shaving and plus cuts himself, and they ask what will be the seen at the site of injury. The answer will be increase in endothelin. So be aware that even though 14 to 15 times this relates to pulmonary vascular constriction, it is technically a vasoconstrictive mediator not isolated to the lungs. Methotrexate, dihydrofolate reductase inhibitor, first-line DMARD for rheumatoid arthritis plus first-line oral agent for psoriasis that fails topicals, causes pulmonary fibrosis and hepatotoxicity and neutropenia. Toxicity can be mitigated with a leucovorin rescue, aka folinic acid, not folic acid. Folinic acid rescue, leucovorin rescue. Albuterol, short-acting beta-2 agonist for asthma, can cause tremor, asked on NBME. Fluticasone and beclomethasone, inhaled corticosteroids used for asthma and COPD, used for prevention / to decrease recurrence of episodes. They have no role in acute exacerbations. For the latter, IV methylprednisone is used. Prednisone Most effective at decreasing the recurrent asthma attacks, but used as a last resort because of oral steroids can cause Cushing syndrome and growth stunting. Montelukast and Zafirlukast. Leukotriene receptor antagonists LTC, D, and E4. Leukotrienes normally cause bronchoconstriction, so these agents decrease airway constriction. LTB4 is special and is a neutrophilic chemotactic molecule. For amino, you can memorize that LTB4, ILA, and C5a are high-yield neutrophilic chemotactic molecules. Can be used for asthma in patients with aspirin-induced asthma blockage of the COX shunts and arachidonic acid down the liposuccinase pathways. So, can be used for asthma in patients with aspirin-induced asthma, blockage of COX shunts, arachidonic acid down the liposuccinase pathway toward the leukotrienes, or for asthma in general in between a LABA and prednisone. Zolutin, lipoxygenase inhibitor, blocks synthesis of leukotrienes, used in some cases, case same as the Lucasts, like Montelukast. Netocromil and cromolyn sodium, mast cell stabilizers used for asthma, prevent release of histamine. Tiotropium, long-acting muscarinic receptor antagonist, LAMA, used first line for COPD. Oladartrol, long-acting beta-2 agonist, LABA, used first line for COPD. As discussed earlier, either a LAMA or a LABA can be used first line for COPD. Ipratropium, short-acting muscarinic receptor antagonist, SAMA, used for COPD, not first line anymore, but still shows up on 2CK materials as an agent that is used. Some old school practitioners still use it, so don't disregard it. Epoprostenol, PGI2 prostacyclin that can be used for pulmonary hypertension. Sildenafil, Viagra PDE5 inhibitor that can also be used for pulmonary hypertension. Nifedipine, dihydropyridine calcium channel blocker that can be used for pulmonary hypertension. As discussed in the cardio PDF, can cause peripheral edema and fluid retention. Omalizumab, monoclonal antibody against IgE, can be used in theory in severe asthmatics who have high IgE levels. Dornase alpha, nucleotidase used to break down airway mucus in cystic fibrosis patients. Guaifenesin, mucolytic agent that softens mucus in cystic fibrosis. Ivacaftor, helps localize CFTR channel to membrane and correct disfolding in CF clearly. Pirfenidone, used for idiopathic pulmonary fibrosis, antifibrotic agent that inhibits TGF-beta mediated collagen synthesis. And that is the end of the pulmonary section. 77 is renal. Okay, 76 is where we end on the pulmonary section. So that'll be the end of our video today. If this was of good use to you, hopefully it was. If it wasn't, I don't know what to say to you. I mean, it is what it is. But I hope you have a great rest of your day. Thank you, and goodbye.